I am Dr. Darshan Jhala, an interventional cardiologist from Mumbai, and I'm going to cover a few topics on heart failure, which are very important topics for all of us who are practicing cardiology and clinical medicine. When it comes to heart failure, we all realize that it is a very dangerous disease. It has very high mortality and morbidity percentages. In fact, at one time, it used to be said that if you diagnose a heart failure patient, the mortality chances of that patient is 50% in 5 years. So half of your patients would be dead in 5 years' time, and it was such a fatal disease. Fortunately, with progress in medical research, we have got now very good drugs as well as device therapies, which have improved the prognosis in terms of morbidity and mortality in heart failure. So we also realize that all heart failure patients are not same. And it is important for us to know whether one type of heart failure is same as other type of heart failure, and if same or different, how they are different, how the management of such patients will be different. So in this talk, I'm going to cover a few different types of heart failures and take you to the current management strategies on such heart failure. First question that comes up for any heart failure patient is, we see many times acute decompensated heart failure. Is this an entity different from a heart failure patient who has come just for the first time to a physician? So a patient who was known to have heart failure goes into acute decompensation. Is that patient different from a patient who has come to us for the first time with heart failure, no prior history or signs of heart failure? So let's look at this. So when you look at such patients, acute decompensated heart failure, the patients are generally older because they have been into the disease for some time. They have worse baseline status because they were already heart failure patients who were either being fully treated or partially treated. They have worse laboratory findings. They're likely to have higher creatinines. They're likely to have deranged electrolytes. And there, of course, they have a known history of underlying heart failure. While a de novo patient who comes to us for the first time has no such history of heart failure. They are likely to be younger, and they are more likely to have better baseline status. The comorbidities associated with acute decompensated heart failure is generally ischemic heart disease, COPD, atrial fibrillation, diabetes. There might be previous strokes, and such patients may have undergone CABG or angioplasty in the past. Such findings of comorbidities are much less in de novo heart failure. Trigger events in ADHF could be either not taking medicines or taking inadequate medicines, infections, excessive sodium intake, cardiovascular complications like development of new ischemia, some intervention like a non-cardiac surgery, or some drugs like alcohol or some anti-malignancy drugs can precipitate heart failure in known heart failure patients, and that will lead to an acute decompensation. While in the de novo heart failure, it is generally cardiac ischemia or valvular incompetence. Or rarely we can get inflammatory viral myocarditis or drug-induced toxic myocarditis, which might be either accidental or self-inflicted, for example, in suicidal attempts. Clinical presentation of ADHF patients, they have dyspnea, orthopnea, and they have edema because this is a chronic condition, and ascites also may be there. De novo heart failure patients may present with cardiogenic shock and acute pulmonary edema. So they are sicker patients, though they are younger, and they have lesser comorbidities, but they may present in an acute condition. And the main pathophysiology is pulmonary and systemic vascular congestion as manifested by breathlessness and peripheral edema. They obviously have LV dysfunction. They have maladaptive neurohormonal activation, fluid overload, and redistribution. While an acute decompensated heart failure is generally mainly the main finding would be LV dysfunction.